The fourth module in the cardiovascular system is mainly about the heart itself, the structure, how blood circulates through it, and the electrical system that controls it. The objectives of this module will enable you to diagram blood flow through the heart and vessels, describe the electrical system of the heart and its regulation by the sympathetic and parasympathetic nervous systems, as well as describe cardiac output and its regulators. The circulatory system includes basically a pump hooked to a bunch of tubes that moves fluid around. The heart is the pump, and it works continuously through your entire life. It never stops. The blood, the fluid, is moved due to pressure created by the heart. It is moved through the system in a bunch of tubes called arteries, veins, and capillaries. The heart is about the size of your fist, but is bigger in bigger people. It's slightly onto the left side, which means your right lung is actually a little bigger than the left to make for space for that. The end is between the fifth and the sixth rib, which is often where a doctor would put his or her stethoscope to listen to your heart. That's referred to as the apex. The parietal pericardium is a serous connective tissue surrounding the heart cavity, forming the pericardial sac. The visceral pericardium, sometimes called the epicardium, surrounds or covers the heart itself. Potential space, the pericardial cavity, contains serous fluid. Pericarditis is when bacteria or virus causes an infection and causes that membrane to swell, which would interfere with heart movement and be quite painful for the person. The heart is located in the mediastinum, suspended within the pericardial cavity. And again, these are serous membranes that cover this, reducing friction. And you can kind of see it as this balloon picture here, the same way that an underinflated balloon, if you put your fist in it where the heart would be, it would have a membrane both around the heart itself and lining the cavity. The myocardium is the muscle wall of the heart and is well supplied with blood. It constantly would need oxygen because it's constantly contracting. The endocardium is the lining of the heart inside. It is simple squamous epithelial tissue, and like all epithelial tissue, lines a cavity. This cavity usually contains blood, of course. The endocardium is continuous with the endothelium, the lining of the blood vessels. Remember from A&P1, the cardiac cells have one nuclei, are striated, and are involuntary. They are more branched than skeletal muscle and all interconnected. The interconnections are kind of these darker lines in this picture here called intercalated discs and contain gap junctions to allow for easy flow of calcium between the cells. Because of these two things, the gap junctions and the tight junctions that hold the cells together, the heart acts like one ginormous cell, which is sometimes referred to as a functional syncytium. The heart gets the most oxygenated blood. Again, it's got to contract all the time. So the coronary arteries branch directly off the aorta. The left branch takes blood to the left chambers and the front of the walls of the ventricles, while the right branch of the coronary arteries takes blood to the right chambers and the rear walls of the ventricles. A coronary angiography is when a catheter is fed through the coronary arteries and it has a camera in it, and the doctor can then view the heart. MRIs are a less invasive way to do the same thing. This next image shows basically how a coronary angiography works. Catheter is inserted up the leg, gets to the heart, put a dye in there, and a little picture is taken. Here's one of another picture of an angiography. On the left side it is a healthy left coronary, and on the right it's diseased. Myocardial cells need fresh oxygen continuously. Because they're contracting continuously, lack of oxygen would stop the contraction eventually, and within minutes the cells will die. And cardiac cells cannot recover. Okay, so they don't come back. During ventricular contraction, however, the heart is squeezed, and of course when the heart is squeezed, there's less blood flow. Therefore, more blood moves through during relaxation than during contraction. So it's very important that the heart contracts to beat, but it's also just as important that it relaxes so blood flow can return to the heart and fill all those coronary arteries. Angina pectoris is the pain resulting from stopping blood flow. Myocardial cells, if they don't get enough oxygen, activates pain receptors, and people can feel that pain. Sometimes it's referred to down their left arm. Other symptoms may be increased breathing rate and increased perspiration. If an embolism or a thrombus blocks a coronary artery, the heart tissue beyond that again dies and can lead to a heart attack. Okay, you can see the surface anatomy of the heart here, right atrium and the right ventricle. Notice there's coronary arteries in that groove between the atria and the ventricle, and more between the two ventricles. The heart has 4 chambers. The top 2 are called the atria and the bottom 2 are called the ventricles. The blood enters the heart in the atria. Think about like an atrium of a building as the entryway, and they leaves the heart via the ventricles. So in this picture here, the atria are the top 2, blood would enter there, and the ventricles are the bottom 2 chambers, and it would leave there. So if you click through this, right atria, right ventricle, left ventricle, the tricuspid valve is between the right atria and right ventricle, and the bicuspid valve is between the left atrium and left ventricle. You can see these little cords that hold those valves down to the papillary muscles. We'll talk about those here in a second and how they help keep these valves closed when the ventricles empty. And you also have 2 other valves, the pulmonary valve and the aortic valve, which keeps blood from flowing back into the ventricles after the ventricles contract. The AV valves are located between the atria and the ventricles. The tricuspid is on the right side and the bicuspid or mitral valve is on the left side. Again, the importance of these are you need to keep them closed so blood does not flow backwards from the ventricles back into the atria. And to hold them closed, use the papillary muscles and the chordae tendineae. These keep the valves closed when the ventricles contract. During contraction, you want the blood to go out the aorta from the left side and out the pulmonary artery from the right ventricle, not back up into the atria. The atrioventricular sulcus, remember, is a groove between the atria and the ventricle. These contain blood vessels, like I showed you in the previous picture. The interventricular sulci is the groove between the ventricles. It too contains major blood vessels. The aortic and the pulmonary valves are referred to as the semilunar valves. Again, they're kept closed after the ventricles push their blood out and contract. Then those valves close so that the blood that you just pushed into the aorta or just pushed into the pulmonary artery doesn't flow back into the heart. Mitral valve prolapse is when the bicuspid valve functions but allows some retro blood flow. This makes a sound that you can hear when you're listening to the heartbeat, and so it's sometimes called a heart murmur. Symptoms include pain, palpitations, fatigue, anxiety. Sometimes it's important to get antibiotics before dental work to prevent endocarditis from a strep infection, because people who have mitral valve prolapse are much more susceptible to this. When the ventricles are relaxed, the AV valves open and the blood moves from the atria to the ventricle. When the atria fill up, this increases pressure on the AV valves, and literally they just open and about 70% of the blood just falls in. There is a weak contraction of the atria that squishes that last 30% out. Then the ventricles are going to contract. The papillary muscles are pulled, which allows the chordae tendineae to tighten, keeping the AV valves closed, so blood goes out of the ventricles through the pulmonary artery from the right side, or through the aorta from the left side, and not back up into the atria. The contraction of the ventricles is the beat of your heart, and the closing of the semilunar valves prevents backflow of blood into the ventricles as the next cycle begins. And when you first hear the lub-dub, the lub sound is when the AV valves close, and the dub is when the semilunar valves close. So looking at this picture again, you can trace the pathway of blood through the heart. It goes into the right atria, through the tricuspid valve to the right ventricle, through the pulmonary valve to the pulmonary artery, goes to the lungs, picks up some oxygen, comes back via the pulmonary veins to the left atrium, goes through the bicuspid valve into the left ventricle, through the aortic valve and out the aorta to the body. If you need that in words, there they are. Vena cava to right atrium, to tricuspid valve, to right ventricle, pulmonary valve, pulmonary artery, lungs. And of course it's going to pick up oxygen there, return to the heart via the pulmonary veins, into the left atrium, through the bicuspid valve, into the left ventricle, the aortic valve, into the aorta, out to the body. A really good website to help quiz you on this, on all the parts of the heart. Check that out. It's a really good place to learn more stuff about the heart. Here's a picture. It's an MRI. It's a coronal or frontal view or slice through the body. It always amazes me in this picture how big the aorta is. Why is it so important that the heart gets highly oxygenated blood? Because it needs to contract all the time, so it should get the most oxygen and the most nutrients. A bypass actually you take a little bit of the vein out of your leg and you put it in the heart around a place where a coronary artery is blocked, which is kind of cool that they can do that. Systole means contraction and diastole means relaxation. The cardiac cycle is the coordination of the filling and emptying of blood by electrical signals that cause the heart muscles to contract and relax. The human heart beats over 100,000 times per day, and every single cycle the heart contracts, pushes blood out, and then it relaxes, or diastole, where the heart fills back up with blood. The atria both contract at the same time, forcing blood through the atrioventricular valves into the ventricles. The closing of the AV valves produces the lup sound, followed by a brief delay. The ventricles then will contract at the same time, forcing blood through the semilunar valves into the aorta or the pulmonary artery. Closing of those does the dub sound. You can see that in this picture as well. The AV valves close, ventricles contract, so you see the pressure goes up. Okay, ventricular systole, the aortic valves close, and pressure goes down again. The sound that you hear again are actually the valves closing. Lub is when the AV valves close, and dub is when the semilunar valves close. Okay. A murmur is when blood flow from the ventricles go back into the atria, which is not supposed to happen. And you can hear different sounds from different spots on the chest, and this is something you would learn as you go through medical school, etc. There's actually a third and fourth sound, but we can't usually hear them because the blood flow through the ventricles and atrial contraction is difficult to hear. Check out this cell. You can see it beating. Cardiac muscle cells are branched and interconnected, so the gap junctions allow for smooth or equal calcium to go through, so they contract all at the same time. And if you grow them in culture, once they touch, they'll actually start to beat right in a plate like this cell is doing, which is a little bit creepy. Anyway, this mass of merging cells acting like a unit is called a functional syncytium. And the heart has two of these, the atrial and the ventricular syncytium, which are interconnected. Okay. The connective tissue in the heart does not conduct electricity, but the muscle cells do. The SA node, or the pacemaker of your heart, is located in the right atrium. They initiate an impulse all by themselves. Nothing sends an impulse to start this. You do truly kind of beat to your own drum. You can do things to speed it up and slow it down through the parasympathetic or sympathetic nervous system, but the impulse is rhythmic, about 70 to 80 times per minute on average, and it generates your heartbeat. Impulses from the SA node travel to the AV node. They do so a little bit slowly so that the atria has time to contract and push that last 30% of blood into the ventricle. The impulse then travels down the AV bundle or bundle of His between the two ventricles, and it does this very quickly, and then back up into the ventricle walls in bundle branches or Purkinje fibers. That allows the ventricles to contract kind of from the bottom up. So again, it can squeeze from the bottom up like squeezing a ball out of a sock, shooting blood out the aorta from the left side and out the pulmonary artery from the right. You can check out this YouTube because we measure these electrical signals using an ECG, and this little YouTube will show that electrical pathway through a picture of the heart. So we measure electrical conductivity of the heart by doing an ECG, or EKG if you're German, and it's not intended to measure the pulse, although you can figure that out from an ECG. It's really measuring the electrical conductivity of the heart. And you get a little graph like shown here. The first little bump in the graph is called the P wave, depolarization of the atria. And then the tall peak is the QRS wave, when the ventricles depolarize. And then the T wave is when the ventricles repolarize. Now depolarization induces the contraction, so you get this little zap of electricity, then the atria contract. Then you get a bigger zap, and the ventricles contract. And then of course it's got to get back, repolarization, and then get back to ready state so you can get to the next one in less than a second. You can't see repolarization of the atria because it's hidden behind the QRS, but it does happen. And then there's this brief period between the T wave and the next P wave where everything gets back on the right side, all the ions move, okay, and you get the second signal there for the next heartbeat. There's another ECG, very normal ECG, P wave, QRS, and then T wave. And often a cardiologist will read these different intervals, and the length of them and what they look like can diagnose different problems with the heart. Literally, you could have a job where you just read ECGs and diagnose people all day long. So why does a doctor do this? What does it tell? It can tell not only if you're having a heart attack, but what area of the heart is damaged. Different arrhythmias, congestive heart failure, all this kind of thing can be determined by an ECG. The last thing we're going to talk about is cardiac output. Basically, it's measuring how efficient your heart is. How well is it working? How much blood is it pumping per beat? And it depends on two things, on how fast your heart is beating and how much blood every beat pushes out. That's referred to as stroke volume. So if your average heart rate is 72 beats per minute and the average stroke volume is 70 milliliters per beat, so every time a heart beats it squeezes out 70 mils, and it does that 72 times a minute, that's about 5 liters every single minute. So all the blood in your body, if the average person has 5 liters, is moving through your heart every single minute. Of course, that's at rest, and if you exercise, you can double or even more than that. Your heart rate can go up quite high, and so your heart would be pushing out even more. So we regulate the heartbeat by the nervous system, either the parasympathetic, which slows it down, or the sympathetic, which speeds it up. During normal everyday life, your parasympathetic nervous system, via the medulla oblongata and the vagus nerves, keeps your heart beating at a steady beat. It keeps it slow, relaxed, whatever it needs to maintain blood pressure. Acetylcholine is the major neurotransmitter used at the end of a parasympathetic chain ganglion. Maybe you remember that from A&P2. So if we blocked the parasympathetic system from working, the heart would actually speed up. In contrast, during stressful situations, the sympathetic nervous system kicks in, norepinephrine is released, binds the beta receptors, and your heart rate speeds up. Again, most of the time, probably 90% of your life or more, the parasympathetic nervous system is more active because your heart is just beating normally. Other things that would cause stress to the body, for example, if baroreceptors in your aorta detected that pressure was too high, parasympathetic nervous system would be activated to try to slow that back down. If it was too low, of course, you'd want to zap the sympathetic nervous system, would zap the heart and speed it back up, because maintaining blood pressure maintains life. Stroke volume is also can be regulated, although it doesn't change as quickly. It's basically, again, the amount of blood your heart pumps out every time it contracts. And it depends a little bit of how much blood is left over after a contraction. So for example, if you squeeze your heart and you shoot out 70 mils, but there was actually 80 in that chamber, there's 10 left. And so that means the next time your heart can't put in more than 70 if it only holds 80. And your heart never pumps all the blood out of the chamber. There's always going to be some left. End diastolic volume is how much goes in after relaxation, and end systolic volume is how much is left over. So if the contraction isn't strong enough to push it all out, then the next time you're not going to be able to fit as much in, and stroke volume is actually going to go down. If blood flow is slow and not much is getting back to the ventricles, then the heart's not going to fill up with blood. You can squeeze next time, but there's not very much blood there. That's also going to affect stroke volume. So this next slide, I drew this to try to get an understanding of stroke volume and some of the things that can change it. We talked about heart rate, and epinephrine, sympathetic nervous system can speed it up. But what makes stroke volume go up? Getting blood back to the heart faster, making your heart beat harder would squeeze more out. On the other hand, if you lost a lot of blood, either dehydrated or stabbed or whatever, or vasodilation of the veins occurred, then blood's not going to get back to the heart fast enough to get pumped out. This doesn't happen quite as much or to the greater extent as heart rate. So cardiac output is more rapidly affected by heart rate change than it is by stroke volume. So you should now be able to identify the anatomical structures of the heart, trace the pathway of blood through the heart, explain the electrical pathway, and a little bit you should have some understanding of what changes cardiac output. We will continue with that in the next module as well. So don't forget, the online textbook has some good stuff. Look at the module review questions. Can you answer them? Check out Google. That Web Anatomy is a good quiz site, and YouTube is always a great source.